Thank you to the audience, and especially thank you to my esteemed colleagues who are here this evening. It is my pleasure to moderate tonight's session. My name is John Haas. I am the chair of radiation oncology at Perlmutter Cancer Center, Long Island. I'm a professor of radiation oncology at the NYU Long Island School of Medicine, and I am the GU site leader for the Radiosurgery Society. So I think we have a really exciting program tonight touching on some really big novel breakthroughs both in surgery, radiation oncology, and in medical oncology. And it is the privilege for me to introduce our first speaker, Dr. Phin, who is a clinical assistant professor at NYU Grossman School of Medicine. He is fellowship trained from Duke University in urologic oncology. His clinical expertise includes using advanced technologies to manage prostate cancer, including transperineal MRI and ultrasound fusion-guided biopsy, robotic-assisted surgery, cryoablation, which is the use of cold to destroy tumor tissues, and focal therapy with HIFU. So, Dr. Tan, thank you for joining us, and I'll let you take it away.
Thank you for joining us today. Thank you for the opportunity to talk about advances in surgery for the treatment of prostate cancer. I have no financial disclosure. Prostate cancer is the #1 cause of new cancer diagnosis in the US. It's also the #2 leading cause of cancer-related death in the country. It's important to know that many of these cancer actually entails low-risk cancer, and majority of patients that we end up treating with do receive and experience some degree of side effects. Prostate cancer is very common. 1 in 9 men in the US will get prostate cancer in their lifetime. Men who are of African-American race are at slightly increased risk of getting prostate cancer, and men with a family history of prostate cancer are also more likely to get prostate cancer. However, it's important to note that most of these men actually do not die of prostate cancer. They end up dying with prostate cancer and usually of other causes. How did the field of prostate cancer screening come about? Well, all of this actually originated back in the 70s, where Dr. Ablin discovered a protein to basically that's found in the bloodstream to basically tell us if somebody has something concerning that needs to be worked up. Initially, when the PSA, which is a blood test, was used to determine if somebody had prostate cancer or not, it was actually not used in the screening setting, but more so to follow patients who had received treatment for prostate cancer. This test has a very high specificity for the presence of prostate tissue. And essentially what it means is that if you do not have a prostate, your PSA value should be 0. Subsequently, though, the FDA in the late 90s or so approved this test to be used to screen men with prostate cancer. The problem with the PSA is that sometimes it's not a great test, as there are reasons why it could be elevated. Traditionally, to diagnose prostate cancer, the prostate is the only organ in the human body that we perform random biopsies on. So there are many trials that I wanted to highlight here, but I tried to pick 3 or 2 that basically determine how we screen for prostate cancer these days. Essentially, when patients present with elevated PSA, nowadays in New York at least, it's actually the standard of care to undergo an MRI of the prostate. And how did this come about? All of this actually came about through some of the studies that were conducted in the UK. In the UK, they conducted this trial called the PROMISE trial back in 2017. Essentially, what they did was that they had 576 men who underwent an MRI of the prostate. All of these men subsequently underwent a saturation biopsy, template mapping biopsy. What that meant is that they biopsied the prostate at every 5 millimeter apart to determine if they were missing any cancer. So what did this trial tell us? This trial actually showed that the MRI is very good at essentially ruling out prostate cancer. That means that if you were to undergo an MRI of the prostate and the MRI came back clean, they're not seeing any areas of concern in the prostate. Depending on the definition that we use on the grade of the prostate cancer, it essentially means that there is an 88 to 93% chance that the patient does not have prostate cancer. This is very important because this subsequently led us to the next advancement in prostate cancer by knowing that we can rule things out with the MRI. Following this, the PROMISE trial essentially showed that the sensitivity is the ability to rule something out of the MRI is 93%. And that's great because typically what we do when we screen for prostate cancer is actually to rule out the disease. Typically, to rule something in, the only way to do that is to undergo a biopsy. And that's where, we perform biopsies in the office, typically to determine if somebody has prostate cancer. And the biopsy has a 96% specificity, which means 96% chance to rule in prostate cancer. Following that, out of the UK as well, they published this trial called the Precision trial. Essentially, a randomized trial is the best kind of evidence in medicine. Essentially, when a patient enrolls in the trial, they no longer get to decide which treatment pathway to receive. And in this trial, what they did was half the patients were randomized to an MRI, half of them were randomized to get a random biopsy. The patients who underwent an MRI, if they were found to have a lesion that is concerning, essentially they underwent a prostate biopsy then. And what this trial told us is that patients who actually underwent an MRI followed by a biopsy, if the MRI was concerning, had a 37.5% chance of finding more cancer compared to the random biopsy group. So since then, it's kind of become the standard of care that almost all our patients who undergo a biopsy would have undergone an MRI before that so that we can actually target lesions that are concerning. At NYU, we also conducted a trial of our own. Typically, when an MRI is done, if we do see a lesion, there are some parts of the world that they do a cognitive biopsy. A cognitive biopsy essentially means that the clinician, the physician, the urologist in this sense, will look at the MRI and they see if there's an area of concern and they will do a biopsy there. So what we did was we looked to see if using a machine to help us fuse the MRI images to the ultrasound images was more accurate at picking up prostate cancer rather than a random biopsy. Excuse me, not a random biopsy, but a cognitive biopsy where the physician is looking at the MRI and using the ultrasound to do that. And even though we found that there was no statistical difference, we found that overall the cognitive biopsy group had fewer cancers compared to the MRI fusion group. So in our practice, it's now standard of care where we use fusion-guided biopsies to essentially target these lesions that we see in the MRI. Why is this important? Well, this is important because the MRI followed by a biopsy essentially helps us to appropriately risk stratify patients. Typically, when a patient comes in with prostate cancer, we stratify them into 6 categories, and the MRI helps us place patients in the appropriate category so that we can treat them appropriately. Recently, out of the UK, they conducted a randomized trial on patients who were randomized essentially through surveillance if they had prostate cancer versus surgery versus radiation. It's important to take a look at this trial because this trial essentially had most patients having lower grade cancer. So 70% of the cohort had lower grade cancer. But what we found that was interesting was that there was less than a 1% difference in terms of death in all 3 groups after following these patients for 15 years. That is important to note because perhaps we've been going about this wrong as a field. Perhaps some prostate cancer is not aggressive as we previously thought. It's also important to note that when we looked at this trial, surgery unfortunately does come with its risk. Surgery can cause urinary incontinence, which is the biggest concern following surgery. That can happen with radiation too, but typically surgery has a much higher rate of incontinence compared to any other form of treatment. And it's important to look that in terms of erectile function, surgery and radiation does affect erectile function to a certain degree. This is usually more prominent in surgery right after surgery, but as you can see in the graph, over a period of time, all treatment modalities does affect this. So essentially, this trial shows that, following lower grade cancer for 15 years, there's not much difference in terms of how long a patient is going to live and whether prostate cancer is going to get them in 15 years. And it also shows that surgery and radiation does have some degree of significant, functional impact. And it's important to note that because perhaps we've been going about this wrong and being a little too aggressive about this. So we need more personalized treatment when it comes to prostate cancer. It cannot be dichotomized. It cannot be a whole gland treatment or not. So essentially with surgery, We know it causes incontinence and impotence. And with radiation, sometimes some degree of rectal toxicity, we know it's expensive as well. And there is some degree of overtreatment. In the surveillance group, on the other hand, meaning if we don't do anything and we follow the patient, we know the cancer could progress. Sometimes there's a psychological burden. There is a cause to surveillance. There is a burden to surveillance, to living with cancer. So there is a middle ground, and that's where focal therapy comes in. Why focal therapy? Well, in this country at least, we've been overdiagnosing and potentially overtreating cancer back in the days. All treatment options for prostate cancer, unfortunately, do risk sexual side effects and urinary incontinence. So what is focal therapy? Well, focal therapy is a treatment approach that essentially we are trying to target the cancer and treating the cancer only with a little bit of a treatment margin to try and render the patient cancer-free while trying to preserve as much functional outcome as possible. And how did we come about with the rationale of this? This all boils down to the MRI once again. The MRI only became popular in the late 2000s or so, early 2010s. And what happened is this actually allowed urologists to have a way to essentially target areas of concern in the prostate. We're able to identify them, localize them, and essentially risk stratify patients to appropriate therapy. A lot of this was also backed by the index lesion theory. The index lesion theory essentially, the concept is that there is a main lesion of concern in the prostate. And from that lesion of concern, it essentially drives biology of the other cancer, even if there is a second lesion in the prostate. So that the concept of this is that we could potentially target this index lesion and essentially help control this cancer. There are various studies done pertaining to this. Essentially, the index lesion does account for about 80% of the tumor bulk. When they study this, when they study patients with metastatic prostate cancer and they sequence them, they essentially find that a lot of this cancer came from this single precursor index lesion, which is how this theory came about. So how do we target this lesion? Well, there are many different forms of energy that we can use to do this. The most common is cryotherapy, which means freezing of this area of concern, or HIFU, high-intensity focused ultrasound. There are other options as well, like IRE, which uses electricity to treat the area of concern, or photodynamic therapy, where we use a specific wavelength to heat things up, or laser. But most institutions are using freezing and HIFU, including us. Cryoablation, the concept of freezing tissue, was actually developed by Dr. Cooper in 1952 in New York City. He was assistant professor of neurosurgery at NYU when he actually developed this device in terms of being able to pass a gas to freeze tissue. He initially developed this for patients with tremors, and he was using it in the brain to determine if he could actually treat tremors. But he was ahead of his time because we didn't have good enough imaging to help us target lesions. This subsequently became popular, and we started using this again in the prostate in the late 90s. And it's been very successful so far. The goal is that, it's minimal invasive, it's a same-day procedure, and there's minimal morbidity. HIFU, which is the other energy modality that we use often, uses ultrasound wave to target a specific area in the prostate. The way I think about this is like holding a magnifying glass under the sun. It doesn't burn everything under the magnifying glass, but what it does is it burns at the focal point. So the goal of doing HIFU would be to use this ultrasound wave and focus it on the area of where the cancer is to essentially cook the tissue down. There are 2 platforms out there to perform HIFU. There are actually 3 platforms now. The 2 most common ones where we send energy wave through the rectum into the prostate to treat the area is the Focal One platform and Sonoblade platform, and we have both of them available at NYU. We also have various trials pertaining to focal therapy at NYU. The Vapor 2 trial uses a steam energy concept where essentially it's directing steam into the part of the prostate where the cancer is to cook that tissue. That trial is actually led by one of my senior partners, Dr. Samir Taneja. He's the national PI for this trial, and we've enrolled quite a number of patients on this. We also have a trial where we're testing a water jet energy modality, which is typically used to treat an enlarged prostate, but we have a trial to determine if that would treat prostate cancer as well, particularly if it's in a certain part of the prostate called the transition zone. Previously, we had the PRESERVE trial open that uses electricity called NanoKnife to treat prostate cancer. That trial has since closed, but we did enroll a few patients into the trial. So the big question is always, which energy modality should we use? General rule of thumb, if the cancer is posterior, meaning closer to the rectum, HIFU would be the best option for that. For an anterior tumor, meaning further away from the rectum, cryoablation would be a better option for that. And the reason behind that is because cryotherapy rods are typically placed through the perineum. The perineum is the area of skin that's under the scrotum. So when the patient's gonna sleep, under anesthesia, we place these rods to freeze particular areas, and it's easier to reach that area to reach the anterior area, and you can safely freeze that without much consequences. Typically, if a patient has multiple lesions that are of concern and they have aggressive cancer on both sides of the prostate, those patients are not good candidates for focal therapy. Hence, there's still a huge role in radiotherapy to the prostate and prostatectomy. The ideal patient for focal therapy, you want the lesion to be on one side. You want it to be real cancer, but we're currently not using it for the really, really aggressive cancer because at the end of the day, this is a cancer procedure and we want to make sure that we are able to render patients cancer-free after treating them. So typically, this is used for Gleason 7 patients or grade group 2 or grade group 3 patients. Ideally, you want them to be far away from important structures like the nerves that control erection in the prostate, and the urethra, which is where urine flows through, and the sphincter, which controls whether somebody leaks urine. Ideally, you want these lesions to be seen on the MRI and ultrasound so that we can target it. And we also want to make sure that we're not doing this for too aggressive cancer because we want, that has not been studied yet. And we want to make sure that we're rendering patients cancer-free. So how is our outcome at NYU? This was recently published at the American Urological Association meeting recently in San Antonio. And we look at our outcome. The infill recurrence rate at 5 years is 12%. So what that means is that the area that we treated and we froze, essentially at 5 years, has a 12% rate of cancer coming back. One may think that's high, but with surgery and radiation, recurrences do happen as well. The downside about focal therapy is that you could recur in the area that has been treated. You could also recur in an area that hasn't been treated. So it's very important to follow up on that. Now, when we look at HIFU outcomes, how is that? So this actually came out of a center in Germany called the Martini Clinic, where the average follow-up was 5 years, similar to our cryoablation outcome. And they showed the same thing. When you do it in high-volume centers and you do it well, you can essentially render you can essentially render patients cancer-free. We do offer focal therapy using HIFU, using the exact same platform as this. We are accruing our data, but we do think we do a very good job because a lot of the concept is very similar. And so far, we've offered this to many patients with good outcomes. So when you look at Google and you look up what treatment options patients are looking up worldwide, we can see that patients are actually looking up focal therapy more and more these days, and looking at prostatectomy is a little less. So we do know that there is an evolution to things, right? We know that back in the days, it was always when we developed the open prostatectomy technique as a field, this was developed at Hopkins initially, and subsequently with various advancements, we started performing it laparoscopically and then robotically, which is what the standard of care is now. And focal therapy is probably even ahead of all of this, and that concept makes sense so far. I do think that as a field, as a cancer surgeon, we're trying to preserve more and more important vital structures because we're starting to learn that, when we treat cancer very aggressively, we also affect a patient's quality of life. And they should come hand in hand in terms of trying to get the best cancer control and preserving as much quality of life as possible. So essentially, there is a role for every option in prostate cancer care. There is a role that typically for low-risk cancer, patients are usually placed on active surveillance. For higher risk cancer, Typically, we still offer surgery and radiation for these patients. The sweet spot for focal therapy is intermediate risk cancer, where patients have just a solitary lesion that is easy to target, that is far away from important structures. So what about surgery? Well, as I previously alluded to, we still offer a lot of robotic prostatectomies at NYU. We have made advances in that as well. Not everyone can undergo focal therapy for prostate cancer. Sometimes the disease biology just prevent that from happening. Recently, what we've been working on was to develop a care pathway to essentially help the patient get home sooner from the hospital. This is actually a multidisciplinary, team approach in terms of how we were able to accomplish this. It starts when the patient comes into the hospital. Essentially, we're trying to load patients up with Tylenol and some pain medications before they even go under anesthesia. We're loading them up with medications. We're trying to give them medications to help with nausea, which can severely affect a patient after anesthesia. During the surgery itself, there are things that we've been trying to do, like insufflating the abdomen with less air. So to perform robotic surgery, we do have to inflate the abdomen with carbon dioxide to get the robot in there and do the surgery. We've been using significantly lower pressure so that there is less air in the abdomen, there is less discomfort and less pain. We are managing fluids with the anesthesia's help, very well. Essentially, they're trying to make sure that the patient stays hydrated throughout the procedure, and they're making sure that we're catching up so that the patient's volume status stays good right after the procedure. That's to make sure that, we can give patients some medications like Toradol, which essentially is ibuprofen's big brother, which works really well for pain. We are numbing out a lot of these port sites really well to try and minimize pain. We are ensuring patients get antiemetics towards the end of the procedure to help with this. When the surgery is done, the patient's brought to the recovery room. In the recovery room, we have a really well-trained nursing team that essentially encourages the patient to walk after surgery. We are trying to resume the normal body function after surgery. That means we're introducing clear fluids, coffee, and tea after surgery to try and get things going again. We're making sure the patient are breathing well. They're using an incentive spirometer to make sure that the lungs are expanding well, and they're transferred to a seating position and overall doing well. Our urology team also checks on the patient multiple times to make sure that they are fit and well for discharge. We also check labs to ensure that everything is stable before that happens. What's important after the prostatectomy is that patients usually will need a Foley catheter, which is a tube that goes into the urinary system. And typically, we leave the catheter in for a week to allow things to heal. So our nursing staff in the recovery room do a really good job of ensuring patients really understand how to take care of this. So how are we doing with this? Well, since we implemented this in the past 6 months, 46% of our patients who've undergone a prostatectomy are actually going home the same day. In fact, in more recent months, that value is actually even higher. Last month, 60% of our patients are going home on the same day. We do believe that most patients can go home on the same day, but at the end of the day, we also want to make sure that the patient's comfortable with this. So not everybody can be discharged on the same day, but we strive to do that, especially if the patient is comfortable and willing to do that. At the end of the day, there is a role for every form of prostate cancer treatment. We treat the individual patient at NYU, and we treat the individual patient, not just the disease, because everyone's priority is always different when it comes to prostate cancer. Each patient is unique, and we should always discuss all of the treatment options because all of them are unique in its own sense. And treatment should be personalized to a specific need and situation, and not just because it's prostate cancer. Thank you.
Thank you so much, Dr. Tan. That was fantastic. Next speaker, this was one of my favorite introductions to make. Dr. Michael Zelefsky is one of my mentors in the field. I was his medical student in 1992, and to have him here at Perlmutter with us has just been fantastic for the whole program and for our patients. So Dr. Zelefsky is the professor and vice chair of radiation oncology at Perlmutter Cancer Center. He has served as president and chairman of the American Brachytherapy Society and also serves as editor-in-chief of their journal Brachytherapy. He has co-authored more than 350 peer-reviewed articles in leading medical journals on the management of prostate cancer with various radiotherapy techniques. Many of these articles, most, have helped change the way that prostate cancer is treated around the world. He's received numerous awards, including the American Brachytherapy Society's Henschke Award for contributions and excellence in the field of radiation oncology, and it's my honor to introduce Dr. Zelefsky, who will be talking about some updates in radiation oncology here at Perlmutter.
Thank you so much, Dr. Haas, and it is a privilege and a pleasure to be together with you and together with our esteemed colleagues who are on this panel. And I think it's a real opportunity as well, because this panel reflecting NYU is truly multidisciplinary in every sense of the word, and we work closely together. And as Dr. Tan had mentioned, to personalize treatment to what is best suited for them. I've been asked to talk about the advances in radiation therapy for the treatment of prostate cancer. And there's been no question that treatments for radiotherapy in the management of this disease has been revolutionized over the years, and especially in recent years, where people who remember radiation from 10, 15 years ago, it is nothing like that right now because of the amazing developments in precision, which we'll be talking about this evening. And here are my disclosures. So let's talk about what prostate radiotherapy and what's new about prostate radiotherapy nowadays. First of all, what's most dramatic is the unprecedented precision, which has allowed the targeting of radiation with exquisite accuracy to the prostate, which has directly resulted in improved success rates. As a result of this improved precision, there's less exposure to the rectum and to the bladder, resulting in low levels of side effects, lower than what we've seen before in 20 years ago, even 10 years ago. Recent studies have shown that surgery and modern day precision radiotherapy can achieve equal outcomes of tumor cure and overall longevity, as we heard from Dr. Tan in some very important trials that have been conducted over the years. And ultimately, as was alluded to before, the decision to choose one therapy over another is often a personal decision based on the various side effect profiles that are prevalent for a particular therapy and what the individual patient considers most important to him. That is critical in making a selection for a particular treatment. So the features of modern day radiotherapy is basically that we rely on imaging. We rely on our radiology colleagues. We rely on the tools of imaging, such as CAT scans and very sophisticated MRIs, to provide for us crystal clear pictures to show us where the prostate is located. And this helps the radiation oncologist accurately target the radiation beams to the prostate. Not infrequently, we utilize markers which are implanted into the prostate, very small metallic elements that are delivered into the prostate. And very often CAT scans are taken during the actual treatment to ensure the daily alignments of the radiation beams. So we're making sure that for each and every treatment that is delivered, that the beams are aligned perfectly to the prostate, and imaging is what's helped us accomplish that. Recent studies have demonstrated that shorter courses of radiation are equal in effectiveness to the traditional longer courses that have spanned for 9, 10 weeks. For many years, back 20, 30 years ago, I was using routinely, as many have, 9 to 10 weeks of daily treatment, which is often onerous for the patients. And recent studies, which have compared those 9 to 10 weeks to a 5-week course, have shown equal outcomes and equivalent side effect profiles. In other words, 5 weeks of condensed treatment is equal in effectiveness to 9 to 10 weeks. But even more importantly, recent studies that have been published in the medical literature have demonstrated that when we look at a 5-session treatment course, which is known as SBRT, stereotactic body radiotherapy, it can be effective and as safe as the 5-week regimen and as the 10-week treatment course. And this has driven us to a large extent here at NYU and in many other centers to consider a 5-session treatment course of SBRT as a standard mode of therapy when treating patients who have localized, confined prostate cancers with excellent outcomes as well. It's important to note, as was noted before, that there are side effects with any therapy. Even the most precise forms of treatment still have some side effects. But fortunately, nowadays, these side effects, serious side effects specifically, are very, very unusual. So for instance, rectal injury or bladder injury requiring surgical repair, even with the precise forms of treatment we use, possible but extremely rare in 1%. Urinary incontinence, as Dr. Tan mentioned, with radiotherapy techniques precisely delivered, the risks are lower with 1% associated with urinary incontinence. Blood in the urine or stool, not seen that frequently anymore. And it's about a 3 or 4% risk of developing that in the future. A little more frequently when patients get radiation treatments is whether down the road patients could develop more frequent urination, which require medication, certainly tolerable, but this is a possibility which we inform our patients about and could occur in about 15 to 20% of patients who get treated. And of course, as mentioned before, erectile dysfunction, the loss of erections, could be seen with any curative treatment that's given, whether it's radiation or prostatectomy or the like. And the incidence of this with radiation is seen in about 20 to 25%. Of course, it depends on the age of the patient, the baseline function of the individual patient in terms of the quality of erections before the radiation is started. And also, there are important medications such as sildenafil, known as Viagra or Cialis, which are very helpful in improving the strength of the erection after treatment. So to summarize, why is radiotherapy so much better now than what may have people remember that their father or grandfather was treated with? Well, again, it's the sophisticated imaging that is now available, which can guide the radiation so much more precisely onto the prostate than we've seen in the past. And this is what's called image guidance, can steer the radiation away from the normal tissues, away from the rectum, the bladder, the urethra, and the bowels, leading to less side effects. But another important element is tracking the motion of the prostate before and during the radiation sessions. Believe it or not, the prostate moves during the actual radiation treatment. That's because the bladder fills up with urine, which could push or shift the position of the prostate. Also, gas within the rectum can distend the rectum and push the prostate position as well. And so by tracking the motion of the prostate, sometimes by placing those markers in, as we mentioned before, tracking can allow us to maintain that accuracy and that precision during the entire treatment session. And in the past, where we didn't really track that motion, we may have missed the radiation high dose, may have missed portions of the prostate. And now, with being so much more precise with this tracking, approach, which is used routinely nowadays, we're able to deliver these treatments with the exquisite precision we were talking about. In addition, something relatively new is that we can place a gel in between the rectum and the prostate, which normally are right up against each other. And that gel, which is introduced under anesthesia as a very short procedure, can be injected between the prostate and the rectum and create a barrier, create a space, so to speak, between the prostate and the rectum, which gives more space for the radiation to work on the prostate and allow less exposure to the rectum during the actual treatment. And here is an example of that, where a needle is placed while an individual is sedated and placed between the prostate and between the rectum, and an ultrasound probe here is what's used to allow us to visualize everything. And this needle injects a gel that dissolves after several months. But during that time when the radiation is administered, we now have a very efficient and helpful space between the prostate and the rectum. So when radiation beams come into the prostate, there's less exposure to the rectal wall. That space or gel creates a barrier between the prostate and the rectum and has been shown in a number of studies to allow for less exposure and potentially less side effects to the rectum and leading to less rectal bleeding in the future. Well, as I mentioned before, a number of studies have demonstrated that stereotactic body radiotherapy is not only a standard of care, but it is a very effective way of delivering radiation for patients with localized prostate cancer. And it's the acronym is SBRT, which is a short course 5-session treatment that can be delivered with various types of machines. The CyberKnife machine, we'll hear from Dr. Haas, who has the world's largest CyberKnife experience, where thousands of patients have been treated with this approach. It's a form of SBRT. Other ways of delivering SBRT is standard high-energy linear accelerators, or an MRI-LINAC, which is a radiation machine that has integrated with it a MRI to take snapshots while the patient is getting treated. And the advantages of SBRT is that it is a high precision treatment, tightly fitted radiation beams around the prostate. It continuously monitors for the movement of the prostate to make any adjustments during the actual treatment. And of course, with 5 sessions given over a week period of time or the like compared to 10 weeks, it's certainly a more convenient for the patient. It reduces the burden of therapy for our patients, which is, of course, extremely important. And knowing in advance where the tumor is located within the prostate is critical for planning prostate radiation. And MRIs, even better than CAT scans, give us so much more information about where the tumor is located within the prostate even. Where is that abnormality? Is it near the capsule of the gland? Is it trying to break through the capsule? Are there any lymph nodes involved that may need to be treated as well? And we're fortunate enough to use here at NYU an MR-LINAC to deliver SBRT, where we are making real-time adjustments to the millimeter on the fly while the treatments are going on. It's a radiation machine integrated together with an MRI. And it really represents a breakthrough for ultra-precision high-dose radiotherapy because we can see what exactly we are treating, and we can plan the treatment for each and every day for those 5 sessions, utilizing a sophisticated radiation plan. We take the MRI pictures, we see what has changed in the interim while the patient is on the table and make these millimeter adjustments to ensure the accurate dose delivery. Even before we turn the radiation beam on, we take another MRI snapshot to make sure that we're right on target. And not infrequently, we see that we need to shift the prostate position during the treatment, and that's because of bladder filling or gaseous distension in the rectum, which moves the prostate on and changes the position. And with the help of the MRI, this is a cross-sectional image where this was where the tumor was located. And while we treat the whole prostate, we intensify the dose, not infrequently, to the area where the cancer is located. And we can do that safely because we can see it with the MRI images that are integrated now with the radiation machine. Of course, there are ways to treat the prostate for when it's more aggressive, when it's breaching through the capsule of the prostate. We call this locally advanced prostate cancer, stage 3 disease. And classically, and we'll hear from Dr. Wise about this, treatment with hormonal therapy together with the radiation is a standard of practice. Hormones, which are really anti-hormones to shut testosterone down, which fuels prostate cancer, is often given for a few months for the treatment and following the radiation treatments as well. It's typically used when the cancer is more aggressive, such as a Gleason score of 8, 9, or 10. And radiation, of course, as mentioned, could be given as a 5-week treatment course, but it could be also given as a more condensed form of treatment, which I frequently utilize here with my colleagues here at NYU, and that is to deliver an internal radiation boost, which is called brachytherapy, delivered as a one-shot treatment under anesthesia, followed by 5 SBRT treatments to the prostate and to the lymph nodes. And studies have shown, in fact, that even more advanced and aggressive tumors, this combination regimen has been associated with superior tumor control outcomes. So how do people make decisions about what is best suited for them? We look at the tumor cure rates. They're very often equal to one another, surgery very often equal to radiation and vice versa. But we have to factor in other quality of life issues such as urinary leakage, urinary frequency, the rectal symptoms, the erectile dysfunction as well. And of course, what are the options when tumors recur? Well, there are various options. The bridges are not closed. Nowadays, yes, surgery, salvage prostatectomy can be used, but as we've heard from Dr. Tan, focal ablative therapies can be used if the tumors come back after any treatments, and even radiation treatments can be utilized as retreatment, which we've seen very good success rates with. So here are my conclusions for this evening's talk. The quality and precision of prostate radiotherapy has dramatically improved over recent years. These treatments have made the treatment much more effective with fewer side effects. And there's now a trend to use short course therapy with higher and more focused doses delivered at each session. Advanced prostate cancers can be treated effectively with hormone therapy together with some combination regimen such as brachytherapy combined with SBRT. And finally, current directions are exploring even using more advanced imaging techniques, using biologic markers, genetic markers, to identify the best treatment for the specific individual patient, which hopefully would provide the best balance for tumor cure and quality of life for the patients we treat. Thank you for your attention.
Thank you so much, Dr. Zelefsky, and always education, even now for me as well. So thank you for that. It was fantastic. So I've been asked to speak briefly about our CyberKnife program here, and I'm going to give a brief presentation on what we're doing with that. So I'm the chair of radiation oncology at Perlmutter Cancer Center, Long Island, and we're proud of our CyberKnife program. This is my disclosure. So this is what we call NCCN guidelines, and this is really what essentially establishes standard of care for radiation. You can look across all risk groups, low, favorable, unfavorable, high risk. SBRT can be considered a standard treatment option. And I think that SBRT has really arrived for everyone. You know, there's many different platforms that work, and I think it's not really just about the platform, it's about the team using that platform. So I use the analogy, you can give the same scalpel to two different surgeons and very different things are going to happen. So similarly, you can give the same linear accelerator to different things, and different doctors, and different things will happen as well. So look at the team also. So what is CyberKnife? It was invented at Stanford University in the late 1990s by John Adler, who's a neurosurgeon. And he combined two things that had never been done before: KUKA robot and a miniaturized linear accelerator. So this is a typical CyberKnife consisting of the X-ray sources, the image detectors, the manipulator arm, and the robo couch. And CyberKnife has called a multi-leaf collimator. So the beams are constantly being shaped and shifted to the position and the size of the tumor in real time. And it's a robotic system, so it has what we call non-coplanar beams. I'll talk about that in a minute. We're able to track the prostate and the tumor intrafraction. So as Dr. Zelefsky said, the prostate's going to move. And very few systems out there, notably the ones that can, are the MR-Linac and the CyberKnife. So while the prostate's moving, we can track that in real time and correct for that movement with an accuracy of less than a millimeter. CyberKnife has 6 degrees of freedom, so it's coming in at an arm at hundreds of different angles, and since it's on a robot, each day the position can be reproduced with 60 microns, so that's really like the diameter or less of a piece of hair. And that's important because you're giving these high doses of radiation, so you want to make sure that you're super precise and not missing, as we've just heard from Dr. Zelefsky. And the CyberKnife has a mechanical accuracy of 0.2 millimeters. This is some of the data showing that with fixed targets, meaning targets that don't move, we're sub-millimeter, and even with moving targets like lung or liver, we also have that accuracy. And again, as I just mentioned, it's coming in at hundreds of different angles. And what that means is, this is a spine tumor, but you can imagine it's a prostate as well. And you see the beams are coming in at hundreds of different angles, treating the prostate, in this case a tumor, on the spine, and minimizing radiation to the normal surrounding anatomy, such as the bladder and the rectum, which we can't do quite as well with different types of other systems. We use artificial intelligence. So prostate, we put these marker seeds in, and we can compensate in real time for the movement of those markers with an accuracy of less than a millimeter. And we can also track moving targets such as lung tumors, liver tumors, by tracking the respiration. This is an example of a treatment of a lung tumor, and you can see the patient breathing normally. We want that. We don't need to hold breath. We don't need to kind of keep them perfectly still. And if we're given that kind of accuracy, we want the patient to be comfortable. They're breathing in and out through treatment, and we're able to track the tumor in real time. This is a paper that we had published several years back, presented at RSNA, looking at over 1,200 patients treated at our hospital with a 5-year biochemical disease-free survival of 99%. And you can see that the PSA just plummets beautifully as a function of time. What are we doing new at NYU Langone? We've opened up a 2-fraction protocol where Dr. Zelefsky had talked about how we're able to get the radiation safely down to 5 fractions. We think we can safely get it down to 2 fractions, and that's better convenience for the patient. It's a protocol done in conjunction with my partner, Dr. John Lashak. And we're also able to integrate MRI planning into the CyberKnife as well and do what's called a simultaneous integrated boost, where we're kind of dialing up the radiation dose where the dominant tumor is, and de-escalating the dose around the normal prostate. So we're able to kind of dial in the dose, take the radiation to where we want to treat the most, and kind of spare the rest of the prostate a little bit better than we did in the past. Dr. Zelefsky was kind enough to include me on a protocol where we're randomizing patients with unfavorable intermediate prostate cancer to hormones versus no hormones, because men don't like hormones, so we think that we are over-treating a subset of these patients, and we're doing that on one of the protocols here at Perlmutter Cancer Center. We have a patient mentoring program where we pair patients up with patients that have gone through this that can kind of guide them through the entire process. This is a paper that was published by my colleague Bob Meyer, who looked at the different treatments that were out there. And with SBRT across the board, it really had among the most favorable urinary and GI toxicity profiles compared to other forms of radiation. This was a survey that was given through the CyberKnife Coalition to patients that had gone through CyberKnife in the past, and 98% said that treatment was a success. 98% would recommend SBRT to others. 93% said there was no interruption to their normal routine, and 99%, nearly 100% of patients said they would choose to be retreated with SBRT. So we are the #2 CyberKnife site in the world and the #1 prostate site in the world, and we're proud of that. I want to thank you again for allowing me to briefly present on our CyberKnife program here. So thank you for your attention tonight. So next, I have the honor of presenting yet another superstar colleague of mine, Dr. David Wise. And David is an associate professor in the Department of Medicine at the NYU Grossman School of Medicine. He's an associate professor also in the Department of Urology, NYU Grossman School of Medicine. He is the service chief of the GU Medical Oncology Program, and he's co-director of the Department of Medical Clinical Investigator Track. He aims to develop new diagnostics and therapeutics to better individualize prostate cancer treatment. He also identifies novel therapies that can reactivate the immune system of people who have had prostate cancer, and is a recipient of the Department of Defense Prostate Cancer Research Award and Prostate Cancer Foundation's Young Investigator Award. So David, my honor to introduce you now.
Okay, wonderful. Well, thank you again for the opportunity to present and talk to this audience. I think these talks are so important to share what is new in the field and what's exciting, and also to be able to present with this wonderful panel with Dr. Zelefsky and Haas. And as they've said, really the team is key. So the culture of collaboration that we have, I think, is quite unique, and I hope that is essentially is felt by our patients as well. But I think it's an important part of our care. I think that the goal of what I'm going to be talking about today is where the medical oncologist fits into this paradigm, and our therapies with some of the hot topics I hope to touch on here in my disclosures, which is we're going to talk about hormonal therapy. Why are we still using this treatment, and what is the goal of it? How is genetic and genomic testing going to inform the changes in care and as our field advances? And then closing with immunotherapy. Why hasn't it worked very well in the past, and how are we trying to design novel strategies currently and in the future? And I think one of the big themes from the prior 3 excellent talks is how technology is being used to dramatically improve the precision and efficacy of treatment for early stage prostate cancer, but also to improve and lower rates of toxicity and outcomes. And I think that what we're trying to do with medical therapies is a bit of both. So we're actually trying to what we call de-escalate, or make the treatment more gentle when we can without compromising effectiveness, but also how to escalate our treatments and really push for unprecedented outcomes and try again to reach that elusive target of cure, which is of course what we're striving for in the medical oncology sphere. So why are we talking about hormonal therapy? Well, hormonal therapy does still remain the most important systemic prostate cancer treatment that we have. As Dr. Zelefsky mentioned, it's really an anti-hormonal therapy because it's testosterone suppression, which is what we're doing. And it remains the key combination partner with radiation for men with unfavorable and high-risk non-metastatic prostate cancer. And in combination with the novel oral hormonal agents, remains the core treatment that we use to control and cure very, very high-risk non-metastatic prostate cancer and control metastatic prostate cancer. And so it really is a crucial element of our current treatment paradigm, and yet it's been around conceptually for a long time. So this story goes back 83 years to Huggins and Hodges. So this is actually a lab director and a medical student who won the Nobel Prize in 1966 for their discovery that if you lower testosterone levels, you can dramatically cause atrophy of the normal prostate and dramatically cause regression and control of widely metastatic prostate cancer. And they figured out the mechanism of that in this key paper that you can see the title of over here in the Journal of Cancer Research in April of 1941. So what did they really find, and why do we still use this? So hormonal therapies lower the body's testosterone level. Testosterone is a fuel for prostate cells. Testosterone lowering starves prostate cancer, and it causes tumor regression and increases the vulnerability to the effects of other therapeutic modalities like radiation therapy. Hormonal therapy can kill cancer cells and can put cancer cells to sleep, but unfortunately does not eradicate all prostate cancer cells on its own. And so eventually, after years of hormonal therapy, typically, the prostate cancer develops resistance to the hormonal therapy through a variety of different mechanisms, and this is known as hormone-resistant prostate cancer. And so why do we still use it? And the answer on some level is straightforward, which is that there are very few cancer treatments, period, that immediately bring the cancer under control and do so 99% of the time. And hormonal therapy or androgen deprivation therapy is one of those treatments. And so it is hard to retire it. It's hard to retire something that is working so well. But in reality, of course, we're trying to improve upon it in a variety of different ways, which I will talk about. But fundamentally, we're trying to both reduce the intensity of it in certain contexts, and that in the example of that is our Intrepid trial, which we've just completed accrual of with Dr. Haas and Dr. Katz and Dr. Zelefsky and the Dana-Farber Cancer Institute in a close collaboration that we've had, where we've tried to show that we can use a lower intensity hormonal treatment in substitution of standard androgen deprivation therapy with radiation for localized intermediate risk prostate cancer. And then in a different study with Dr. Zelefsky's pioneering phase 3 trial, trying to show that maybe we can avoid it altogether in certain contexts when we use stereotactic radiation with either the MRI-targeted stereotactic radiation or the CyberKnife platform. So can we try to avoid it? Can we try to shorten the duration of hormonal therapies? And in reality, can we get to a point in the context of metastatic prostate cancer where instead of using it as a long-term control, can we use it as an initial way to stun the cancer, bring it under control, so that we can come in with more potent and tailored therapies to cure those microscopic residual cells? That's really, I think, right now the vision for how we can ultimately use it. I don't think that we're gonna eliminate it, as far as I can tell, although you never know. But that right now is my main vision for what we can do and how to shape the future of treatment of prostate cancer. And so that directly dovetails into this tailoring of therapy to the genes. And we're really still, I would argue, just at the tip of the iceberg of this. So how is genetic testing involved right now in the standard of care for prostate cancer? And the answer is there are two types of genetic testing. They're called somatic testing and germline testing. And what those words mean is that somatic testing is understanding what I call the blueprint of the cancer. So what are the genes that make this cancer tick? And that is true regardless of the inherited predisposition. No matter what the cancer is, these days, we can almost always find what are the key driving genetic changes that encompass the blueprint of the cancer. And then there's another type of genetic testing, which is specific and tailored to the inherited genome, what a person is born with. Those are two different types of tests that we recommend as a standard that we do at NYU. in a very, I think, unique way. And I'll talk about that, but this is the blueprint, right? So these are the different genes, and this is too small to read, and I put it that way to tell you that there's a lot of different genes, and they are involved in multiple different mechanisms of how cells grow, divide, control themselves, and how the cells actually interact with the immune system. Because we now understand that that is probably very much related to what is controlling the immune system's response to the cancer, or the different genes that are mutated. And so we search for these with standard tests that we can employ. And we find that there are a variety of inherited genes as well that people are born with, although only about 10% of people with metastatic prostate cancer are born with a clear single gene that predisposed to the development of cancer. Importantly, some of these genes predispose to male or female cancers. So that's important. So, patients of mine will say, well, I don't have any sons, I have daughters. And I tell them, actually, I'm most concerned about testing in your case, because those are, if we're looking for a BRCA2 gene, that's a gene that actually predisposes to breast or ovarian cancer, and that can be prevented and screened for. So it goes to male or female, and it's important to understand that. And so at NYU, what we're doing is a few things that I think is really exciting. So first of all, we now have the capacity to test for the inherited genetic mutations in my office, in the office of the oncologists, rather than having to wait and for a referral to a geneticist. And so that's a point of care program which we've developed together with our genetics colleagues at NYU, where that testing can be done real time, and with the results coming back in about 3 weeks. And so that's the old model, was waiting 6 months, which is unfortunately still how it works in a lot of places. We have our own FDA approved genomic blueprint panel called the Genome Pact assay or test, which looks for 607 different genes, which are the most commonly mutated genes in prostate cancer. We've also worked very closely with the outside vendors that provide the best-in-class technology for what we call liquid biopsy, because in some cases we can't get a tissue biopsy and we want to identify the genetics of the cancer that way. And in some cases, the cancer genome evolves over time with treatment. And so we want to be able to dynamically monitor the genetic features of the cancer. And so this is a simple blood test that allows us to find the needle in the haystack, the genes from the cancer that have spilled into the blood that we can identify in the bloodstream. And so these are the ways that we're trying to robustly incorporate genetics into the standard of care. Now, this very much relates to immunotherapy. And why is that? And that's because of a simple sort of paradigm here, which is something called tumor mutational burden, T-cell infiltration, and PD-L1. And what that means is that the more genes that are mutated in a cancer, the more the cancer looks like a foreign entity, almost like an infection, and the more likely the immune system is able to identify and detect that cancer. And the more likely that immunotherapies that boost the immune system are able to help the body's immune system detect and be a curative or treatment for the prostate cancer with a lot of effectiveness. And so I want to leave time for questions, so I'm not going to go into too much detail here, but just to say that genetic testing is what allows us to detect this level of genetic mutation, and what allows us to determine if a cancer might be very sensitive and treatable with immunotherapy. And so which prostate cancers are these? So unfortunately, it's not as many as we would like. So there are the prostate cancers on the extreme end of the spectrum. There have many, many different mutations, and they're called MSI high cancers, which stands for microsatellite instability. And that means a cancer that has many, many different mutations and that can be highly treatable with immunotherapy. The vast majority of prostate cancers do not have these particular mutations. But what we've now understood is that there are other mutations that might still give us very tailored treatments of how we should best treat the prostate cancer. And so I'll leave off with this slide of, is there a future for prostate cancer with immunotherapy? And the answer is yes. And so I'm happy to say that we have a variety of exciting new immunotherapies that work in fundamentally different ways. This is not, Yervoy and Opdivo and Keytruda, which are very, very successful treatments in melanoma and non-small cell lung cancer and bladder cancer, but unfortunately have had a series of failures in prostate cancer. We are not testing those agents because we know that they don't work well for the vast majority of prostate cancer. But what we are testing are a new generation of agents that directly bring the immune system to the cancer. And those are called bispecific T-cell engagers. So one of those that is, we'll have the trial soon, is this J&J antibody, which does not have a name yet, okay, but is now going to be in phase 2. And we'll have it open here by next week. We have another trial called the PRESERVE-06 trial. I haven't had time to talk about Pluvicto, but that's obviously one of the more promising FDA-approved treatments. But we think we need to rev up the immune system to really make it the treatment effect more durable. And so that's a trial that I am leading at NYU. That's a global study with 20 sites where NYU is leading that trial. We don't have CAR T cells. That's those are genetically engineered T cells from the patient that we modify and use to target the prostate cancer. Those have historically been too toxic. They've had too many side effects. But I can see a time in the near future where those are going to be available and far safer. So I think that is coming. And there are multiple other non-immunotherapy mechanisms that I haven't even talked about here today, including alpha particles. So we have 2 of those on trial in the next 2 months, the fusion and convergent trials, androgen receptor degraders, which is a new way of blocking the androgen receptor, and antibody drug conjugates, a new way of bringing even chemotherapy, but in a much more precise way to the prostate cancer cell. So I'm going to end off with that. Here's our number if there's a need for a consultation, and I wanted to end with that. So thanks again.
Thank you so much, David, Dr. Wise. So I think we're going to open it up now to questions. So what protocol would you recommend if you're on active surveillance?
Around the world, there actually isn't a standardized approach to active surveillance. I was recently part of a survey where we were trying to debate what's the best protocol to follow people on active surveillance. And the option in the debate was whether we do a repeat biopsy, which we usually do on active surveillance, and where the time point would be to do that. And there wasn't a consensus between 6 months to 18 months. But to make things simple, most of us at NYU would probably do a repeat biopsy at 1 year for the majority of patients who are on active surveillance. Typically, that means that from the time of your diagnosis, we actually check your PSA, which is the blood test, every 6 months. On the 1 year mark, if your PSA continues to be good, we then think about doing a scheduled biopsy. Typically, we do an MRI at the 1 year mark, and we do a biopsy based on that. Some of our partners would consider doing a second scheduled biopsy at year 5, but that is also not the standard of care. Throughout the time you're on active surveillance, though, what happens is that we do 4-course investigative studies, meaning when the PSA goes up and it's unexpected, and clearly there's a huge jump in your PSA, what we do is that we will get an MRI in that setting. And typically, if we see that there is a change in the MRI, we will consider doing a prostate biopsy at that point. It's important to note that the PSA value can be affected by many things. Common things would be things like inflammation, infection, and many a times in the prostate can be inflamed for reasons that we do not understand. And it's tough to tease that out, but the big thing that we want to make sure we're not missing is prostate cancer when that goes up.
So patients that have a slight increase in PSA, are there different types of blood tests or different types of PSA that might help stratify the need for a biopsy?
Yes, although I think most practitioners still use the total PSA, and not just simply the value of the PSA. I think it's important to emphasize, but to look at serial values, the movement of the PSA. We call it also PSA velocity. I don't think a decision should be made based on one value. And for that matter, I frequently ask patients I see, was this PSA obtained from the same laboratory? Because consistent laboratory assessments are critical. So if you're going to be followed, especially for an active surveillance program where the PSAs are, to begin with, somewhat low, it's important to monitor the PSA in a serial fashion. I think other things beside the PSA would be getting a sense from the biopsy material. And as alluded to by Dr. Wise, we frequently utilize a Decipher score, which is a genomic assessment looking at 22 various mutations to better understand how aggressive or not the prostate cancer is. So I think overall, PSAs, not just looking at the absolute value, but serial movements of the PSA are important, as well as other factors.
And could you elaborate also for the audience, different types of PSA, free PSA, 4K, things like that?
I mean, those are, you know, those 4K are another prognostic assessments of whether a biopsy could be needed or not. And we frequently use that information. I personally must say that I think the PSA in and of itself, and not just necessarily the free PSA, but the total PSA and its movement, I would want to emphasize is more important to focus upon and monitor, whether it's post-treatment or prior to any treatment, in considering whether to continue with active surveillance or an active treatment.
Will taking age-related eye disease medications for eye health increase the risk for prostate cancer?
That's a great question. So, you know, I think that there are some concerns with certain supplements and vitamins in terms of increasing the risk of prostate cancer. It goes into sort of a broader question of you know, prevention of prostate cancer, and some of the studies that have been done with agents like finasteride, agents like selenium and vitamin E. And, you know, there have been some very important studies over the last 25 years about this. You know, I think that in terms of what we've learned is that finasteride and Proscar probably does lower the risk of low-grade prostate cancers, and probably does not have any real effect. And there might even be a slight increase in the risk of high-grade prostate cancers in men who take those that hormonal therapy. And then, you know, the most sort of surprising study was related to you know, selenium and vitamin E in terms of, you know, potential risk of lung cancer in a large randomized phase 3 trial run by the NCI. But I don't believe that the vitamin E level in AREDS would have an effect. I would actually defer to Dr. Tan on that. I'm glad he's on the call, and see what his approach is.
I think for vitamin E, the relationship between vitamin E and prostate cancer is still very controversial. There was a trial done on the subject called the SELECT trial, where they looked at selenium, vitamin E for screening, and they found that, you know, maybe it was a slight increased risk of having prostate cancer. You know, many of these trials, though, are very tough to interpret, because Usually when they do a large, when you look at dietary habits and, various vitamins and whatnot that causes cancer, it's always plagued by many, many confounders. Because at the end of the day, many of these have a small effect size. That means that you really have to study a lot of patients to actually see a difference in terms of that. And when you have a trial like that, we know that it's a small effect size. We know a lot of things can change the biology of prostate cancer. We know that, if you go on a plant-based diet, for example, one of my senior partners, Stacy Law, published extensively on this, that it actually might slow down the progression of prostate cancer. But those are small effect size. When we treat prostate cancer, surgery, for example, radiation, focal therapy, that's a large effect. You study 5 patients, you see what they get done, you know that it treats the cancer. When we look at supplement data and trials pertaining to that, a lot of times it's a very small effect size. So it's very tough to interpret. And I tell patients, hey, at the end of the day, some supplements are bad for you because many of these supplements are actually not FDA approved. They're not FDA approved, essentially. And what happens is that, when you are marketing a product as a supplement, you actually do not need to prove efficacy. That means you don't have to prove that that actually works. All you need to do is you need to prove that when you're selling vitamin E, it has to be vitamin E. You cannot sell vitamin C and say it's vitamin E. That's all the FDA requires. So at the end of the day, the data is weak, I would say at best. And I probably wouldn't change my practice in any way.
Patients that are being referred for genetic counseling, how do you determine who would do that? And do you ever recommend just the patient or the patient's family as well, children?
Yeah, it's a great question. So we would recommend typically that that the patient have genetic testing, and that the patients who are eligible for genetic testing are patients with high risk or metastatic prostate cancer, patients who have multiple first-degree family relatives with a qualifying diagnosis, and so that's so it could be a high risk or metastatic prostate cancer. The eligibility for this and who the insurance pays for is relatively confusing, and so it's hard for somebody, I think, to necessarily remember, but that's why you should talk to your oncologist about that. And so, but if you qualify and insurance pays for it, then the patient gets tested. And if the patient has no concerning inherited genetic findings, then there's no need for the family members to have what's called cascade testing, or for the other family members to be tested. Now, of course, if there's another family member, for example, the patient's wife has some sort of predisposing condition that is of a concern, the children may need to be tested regardless, but not by virtue of the patient's history, but by virtue of the other family members' history. So that's what we usually recommend. A big part of the testing is the genetic counseling, because that's really, these tests should not be performed in a vacuum. It's not like getting your blood counts checked. These tests have major implications for family and for anxiety, and so it needs to be done with a genetic counselor on board who can really explain what the test means and how to act on it, who should be informed, how to inform. So that's why what we do is we explain the test in basic terms with a good informational video ahead of time. That way the test can be done quickly, but then the genetic counselor calls the patient with the results to make sure that there's a good action plan that gives good patient satisfaction.
New patient comes in with a new diagnosis of prostate cancer, and it's really easy to get overwhelmed with all the different treatments that are out there. So any advice you can give to a patient who's newly diagnosed and just is hearing all these surgical, radiation, different types of options, and how do they kind of weed through that to make a decision?
Extensively evaluate what we are dealing with, and that is often with, of course, measurements of the PSA, and as I mentioned before, serial measurements of the PSA, getting a high quality MRI, especially before any kind of a biopsy, but even after a biopsy if it was never done, and to really have that critically evaluated by MRI radiology experts to better understand where is the disease exactly. Is it abutting against the capsule? Is it through the wall, or is it contained? Is it close to the urethra? Is it very localized? That obviously has implications if the patient is a candidate for focal therapy, as we heard earlier this evening, or the possibility of radiation, or if it's all contained and the Gleason score is not high, we may not need hormonal therapy. So the PSA, the MRI, and the biopsy information is critical. But now, interestingly, we have even more tools to help us really get a better idea of what we're dealing with. And these two relatively new tests, one is the PSMA PET scan, especially for more advanced disease, gives us a much better sense of where the disease is located. Is it in the prostate only? Is it in the lymph nodes? Is it in the bones? And more often than not, it isn't. But this gives us a global assessment of what's going on in the body. And as mentioned before, some of these genomic tests give us an additional sense of how aggressive or not it is. I think it's important, before getting overwhelmed, for each individual patient to get the appropriate information first, and then seek out the multidisciplinary experts, understand what the options are. And what I tell patients very frequently is that there's no right or wrong answer. In most situations, you could be handled extraordinarily well with one treatment or another. You really have to factor the quality of life issues. What are those parameters that are important for the individual patient? There's some patients who really want to, quote unquote, get it out of their body, and surgical approach may be better. There are others who really want a less invasive approach. There's some patients who have lots of urinary symptoms and may be better off with some kind of a surgical approach. And there are others who have cardiac or other medical problems that are better steered away from surgery. And that's the purpose of seeing, in a multidisciplinary setting, multiple experts and hearing what are the best options and making a decision based on that.
Yeah, I think you hit the nail on the head. I mean, I think there is value to going to an NCI-designated cancer center where you have access to all the specialists, and it is a collaborative approach, right? We have access to protocols. We have access to seeing the different specialties and subspecialties. So I tell my patients, take a breath. Prostate cancer is a cancer that you do have the luxury to do your homework. I argue that any physician, this doesn't happen very often, but I hear in the community that are forcing you to one treatment or the other and not letting you see the other specialist, they're not doing you a service. So for those that are newly diagnosed, take a breath, seek multiple opinions. If you have the option to go to an NCI-designated cancer center, we've kind of been vetted to go through this process where we can provide the highest level of care and have access to protocols. And Dr. Wise has been visionary for our program in opening up radiation protocols and chemotherapy protocols and hormonal protocols and genomic protocols and drug delivery. So I think it is important to kind of do your homework and seek multiple opinions and go to a collaborative center. I could take a first swing at that. So prostate cancer, I argue, it's like a baseball at bat. So it's one of the few cancers where you get a few swings at this thing. So if you have a surgical approach, prostatectomy, for example, and it comes back, you're a candidate for radiation. And it used to be oftentimes we radiated many patients right out of the gate after surgery, depending on some of the pathology. But there's been an evolving body of really good phase 3 literature where patients were randomized to either radiation after surgery if they had bad pathology, or waiting till the PSA started to rise a little bit. So it's become a new standard to kind of wait a little bit in many patients to see if they need radiation. If it comes back after radiation options, Dr. Zelefsky is one of the world's expert on giving salvage radiation, either with radiotherapy, or he now has a protocol open for using the MR-Linac to do salvage radiation. So, and I'll throw it out to the surgeon and Dr. Zelefsky as well, but, I think that, there are multiple options. It's like a baseball at bat, and you get a couple swings at this thing, even if it comes back.
I think Dr. Haas nailed it on the head. So typically after radiation, if it doesn't work, there is also an option for us to utilize some of these focal therapy energy modalities like cryoablation and HIFU in the salvage setting. I think that with our latest development of the PET scan, which was recently FDA approved about a year or two ago, where the PSMA PET scan was approved, it actually allows us to occasionally, at times, even comfortably follow patients who have no evidence of disease on the PET scan. If nothing is lighting up on the scan, for example. So I think at the end of the day, once again, we taper the need of the patient based on their priorities. Because, for example, if someone comes in their 70s, for example, and they had radiation therapy, and he's cancer-free for 15 years, and the cancer subsequently comes back, and if he's a very healthy individual, yeah, we can certainly still consider treating this. But at the end of the day, we really try to weigh what we can do to optimize the patient's quality of life and what his priority is in terms of how aggressive he wants to pursue this. For example, if his family members are living past their hundreds, for example, he may want to be more aggressive about this. If if he looks very healthy, he looks like a 75-year-old and is pretty active. Whereas on the other hand, if he's plagued, and unfortunately plagued by various chronic conditions, his best option, if his priority is to focus on quality of life, perhaps there is an option of maybe not even doing anything. And that process is called watchful waiting, where we can essentially wait for the disease to progress, and it may never progress, or it might progress in the next couple of years. And subsequently, we can consider studying some form of hormonal therapy, like what Dr. Weiss mentioned, to essentially control the disease and to try and optimize the patient's quality of life.
I agree with everything that's been said. And one thing that we don't say, fortunately, nowadays, because of innovations in technology, that it used to be told to patients that, well, get the surgery because you could always get radiation afterwards. But if you get radiation, you can never get any other treatment if it comes back. And I think, as we've discussed here today, with the innovations in radiation delivery, focal ablative techniques, and the like, there are significant options that are available to the patient if treatment is considered after a tumor comes back, because of the innovations and the precision that we're now able to give these kind of treatments more safely than ever. And so I think there's a lot more hope and promise for patients getting treated with any kind of prostate cancer because of the real revolutionary developments that have been across all of our specialties.
Just to align with everybody, it's really one of the major advances here has been PET imaging. And so in a patient with a PSA that's rising again, where historically many men were treated with hormonal therapy just as a reflex response with a small PSA rise, that really shouldn't happen anymore. All men should really have a PET scan at the time of PSA rise to really confirm that we know exactly what we're treating. We have hormonal therapy as a backup plan. It's effective, but we don't start with that. And I think that that's an important sort of philosophical point, was we really try to be precise and tailored to our patients.
One of the things that I like most about our field now, so I'm a contemporary, a little bit younger than Dr. Zelefsky, but we started around the same time. And when we started, metastatic disease for prostate cancer was considered fatal or close to fatal. And now with the advent of SBRT, not just to the prostate, but to low volume metastatic disease, we're able to keep many of these patients and cure them. If you have low volume metastatic disease, we're able to aggressively chase them and really make it almost like a chronic disease, like heart disease or something else. And that's been one of the biggest breakthroughs in our field in radiation over the past decade.